Good morning to everyone. Having talked about the Aravind Eye Clinic Pondicherry, known for their clinical services and academic and other areas, we have to stress, and we have been stressing on what the clinical sciences are based on. That is why basic research and basic science into clinical science we want to integrate. That is why this whole thing is. Aravind Eye Care is known for services, which I need not repeat whatever has been said, academic programs of residency and fellowship and other areas, and also consultancy, capacity building of a LICO, a products division of RLab and others. But now my duty is to stress on the basic research, what is going to help the clinical scientists, and we have to develop not only the clinicians and the scientists, but also in between a clinician-scientist approach in order to develop and keep the same theme as to reduce the needless blindness. This has been already told. This is the Vision 2020 statement that we have been doing an excellent service in all these areas. But there are areas where the people we have diagnosed and tell the patient that you have this disease, sorry, we cannot do anything. You have to live with it. And that is the verdict we give, which we, as medical officers, we are not supposed to do, but we are helpless to do right now at this stage. But now the stage is changing all over the world, not only in India and other areas. Just examine, just see glaucoma. We have been telling this is a controllable disease. Is it possible to make it as a curable disease? That is what we have been talking about. And also inherited retinal disorders, retinitis pigmentosa, they are talking about genetic mutations, genetic variations, and can we do anything about it to change the gene therapy and gene mutation, all these things. This is what we have been talking about. This is not anything mythical. It is happening elsewhere. When it is happening elsewhere, wouldn't be when we have all these facilities, clinical and basic sciences, faculty, science, everybody is here with Vision 2035. Can we do something to new biomarkers, molecular genetics and gene therapy, stem cells, which we are already at it. That is what I am going to say. What are the facilities, what we have to make you know that you can utilize that facilities and develop the science. That is what I want to present it. Not that I'm going to talk about the theory part of it or research, what is happening, but what are the facilities, resources which are available at your hands, which you can make use of it. That is what is. And the basic science and the clinical science, the interaction, they took place even as early as 1980s. There was a disease, a Yields disease. There is a disease still. And we did a clinical and immunological research. Even at that time, that Carl Kuffer, who is the director of NEI, he started this Yields disease at Madurai Aravind Eye Hospital, along with Madurai Kamaraj University on immunological studies. So even at that time, we had clinical and the immunological basic science. And we also found out there are two abnormal proteins which are in the serum of Yields patients, which are typical of immunological change, which we did, but we didn't go further because at that time we were not there. The first genetic lab was started in collaboration with University of Iowa with Ed Stone. He was very helpful to send his technicians, stay with us for 3 months, and give the economic help also with the $20,000 per year for 3 years to develop the genetic lab, even at that age, 1998. And that is the time we started with the Leber's congenital amaurosis with AMRF. But we have been supplying the biomaterial to other countries. We have not been doing it. But that is the initial stage, set the stage for, say, basic science and the clinical science, Leber's congenital amaurosis and it. But after that, AMRF has been with our pediatric ophthalmology the department, Dr. Vijayalakshmi and her group also found out that anything we could do for the genetic study of albinism, anything you can predict the albinism children, albinism family in this, and also in retinoblastoma studies. Either the second child will have the retinoblastoma gene or anything. So with that, we started all this genetic studies and proteomics. You must know that protein changes in the protein in the serum and the blood occur much earlier than the systemic symptoms develop in the body. So if we can predict, if we can find the biomarkers in the case of proteomics, you can detect earlier, detect glaucoma even before the symptoms appear, detect diabetic retinopathy before the clinical signs appear in the retina, and you can detect retinitis pigmentosa with this, the genetic changes in the biomarker. This is what, again, it is not a myth. It is not something story you are running. It is happening. It is elsewhere happening. Being clinicians, you must be aware that you need not do it, but you must be aware that you must do something to your patients, advising something to that. Fungal keratitis, the cornea people are doing excellent work on proteomics, changes in the tear proteins, and change the whole pharmacopoeia. The research in the Aravind Medical Research Foundation has done an excellent research in changing the British pharmacopoeia to change the treatment for fungal keratitis, finding out the causative organism, severity of the fungal lesions in the fungal. That is proteomics. Changes in the, it is not anything which is not occurring, it is already happening. Now with artificial intelligence and all these investigations that are going on, which I will not go into the details, as there are so many people are going to talk about it, and automated detection of glaucoma before changes clinical signs appear in that. But what I want is clinical research. But clinical research integrated with the basic science, collaborating with the basic scientists. Basic scientists are not available in Pondicherry or Coimbatore to find out what, but the scientists, clinicians are available to ask questions, whether I can treat this glaucoma, whether this child is going to have glaucoma because this child is coming from the family of glaucoma, because it has been proved that glaucoma family has got a mutation in the gene, but the disease is not manifested, but the mutation is there in the genetics thing. So whether you can change the mutation, not that the optineurin or myocilin you are going to change, but at least whether you can change the mutation or the gene therapy, or these are all the areas where the clinicians can turn out the researcher, working with the scientists. Scientists are experts in proteomics, experts in the genomics, but not clinical aspect. When these two people join together, and they can ask questions, and then but it is in your hands, because you are facing the patients. You are not the scientists. You are going to ask, and they will answer. They will have to answer. That is it. That is what translational research, from the basic science, you translate to the clinical science. Retinitis pigmentosa, RPE65, they are doing gene therapy for retinitis pigmentosa. It is not successful. It is successful, but it is not very popular. In the Luxturna, it has been approved by the FDA already. And pre-symptomatic diagnosis of glaucoma, even before it happens in RPC or anywhere in the optic nerve head, before even in the increased pressure or the angle trabecular measure, something, and a productive biomarkers and diabetic retinopathy before We all said that there are risk factors. Diabetes have long duration, and people are uncontrolled diabetes will have diabetic retinopathy. But even before that, pre-diagnosis of diabetes, all diabetic people, if you do some tests as clinical lab tests, if we can attempt to find out the changes in the proteins, biomarkers, you can predict that this patient is going to develop a diabetic retinopathy, or this patient is likely to develop even proliferative diabetic retinopathy or non-proliferative. You can take steps. You cannot prevent diabetic retinopathy at this stage, but at least you can prevent people going blind due to diabetic retinopathy, and because of the intervention at correct time, correct diagnosis, correct management of all systemic parameters, which you can do it. This is the fungal keratitis. I have already. Retinoblastoma part of it, extensive work is being done at Madurai with the Ring of Hope as well as AMRF, and genetic testing, next generation sequence of genetic, is very helpful even for the public to have genetic testing at low cost. This is available at AMRF. This is very, and all these things, nano ophthalmology. How many people are prescribing medicine for glaucoma? Part of it, one drug, or two drugs, or three drugs, twice a day, three times a day. How many people in the villages can apply those drops? And that is what it is. How much expensive it is, socioeconomic. You get cataract surgery done and save 2,000 rupees. But these people are spending at least 3,000 or 4,000 rupees per month per patient, per drug. Whether is it possible to develop a nano technique, nano device to sustainable release of drugs? It has been found in Singapore, journals and Nanyang and others. It is possible by nanomedicine. We have scientists, we have labs, we have people to ask questions on that. It is possible to develop the nano. Only thing is we have to think that we can do it. We have to always think on that possibilities. And stem cells, and people are already preparing the scarred cornea with multiple layers of limbal stem cell, buccal, mucosa, limba, all those things preparing, done at Madurai. It is not textbook description. People, as alumni members, you should know this is possible in our hands. And stem cells, also it is possible to dry ARMD, and all the photoreceptors are all dead. And now regenerative medicines. It is stem cells with pluripotent stem cells injection, and it can stimulate the development of the photoreceptor regeneration. All these things only possible because of the clinician scientist approach. You have to ask questions to the scientists. You need not do science, but for that, these are all the things which are translational research and biomarker diabetic retinopathy, which we are told. We have come to our close. This work is going on at Madurai to find out the protein changes in the biomarkers. It was 36 proteins, and now we have come up to the 9. So is it possible to slow down to 1 or 2, so that people who are having these protein changes are likely to develop diabetic retinopathy, the biomarkers? And how predictive biomarkers, even before what we say that early diagnosis may control diabetic retinopathy, but early diagnosis only after blood sugar, everything. Even before blood sugar comes, if we can find out, that is where the biomarkers are going to help. And this is what is the extensive work being done at AMRF, predictive biomarkers for disease process before the onset of the diabetic retinopathy. Can we predict? Can we have a clinical lab test just like HbA1c to find out diabetic retinopathy? And you can suggest more the lifestyle and drugs rather than extensive intravitreal injections and lasers and vitrectomies procedures of causing so many things. We can do it. Indo-UK collaborative studies are going on in the research, which you should know as clinicians that we are not too far to develop this research area to develop biomarkers. And glaucoma, we have already told, it's not due to the excess or lower of myocilin or ophthalmic, but there is a mutation gene, and that you can do a primary open-angle glaucoma by genetic. Is it possible? And is it possible to screen the family? You must all know, you must be treating diabetic, the glaucoma patient. Are you examining the family people? No, if you have that knowledge of spread, general awareness that you should examine the family. There is with Tirunelveli, there is a group doing a family. A 9-year-old girl from a family has got genetic mutation, but not exhibiting the disease. But he can exhibit the disease at any time. Now we have to expect what we have to do, whether we have to wait and watch that for the patient to develop that glaucoma, or you have to intervene with it. This is the science. This is where we have to give the contribution to the science. Not treatment is technology and techniques are improving in diabetic retinopathies, glaucomas, cataracts. Half an hour, 5 minutes, you can go all these. But are we going to do something for this kind of unfortunate individuals who are given a death verdict that you are going to become blind, but we are helpless? That is where is very important. And these are all the transnational research. Now coming to the stage where why Pondicherry is very much, see, we are trying to develop the basic science here at 4 research centers in Chennai, Pondicherry, Coimbatore, and Tirunelveli, where we develop all the infrastructure facilities which they can do, basic facilities like DNA or genetic or whatever, the basic things can be done by a trained technician. And this can be, and this is the lab which I think Pondicherry has already set up, and all the 4 centers have set up. They will do all the investigations. They will share it with the basic scientists and facilities which are available at Madurai, and they will have consultation with the basic scientists who are there at Madurai. It's just like in the next room with the technology, with virtual. They can consult. If they want to change, they can change it. They can do that. This is where, this is what it is. You can see on the left-hand side, the center at Pondicherry or something. And on the right side, you have got the basic science with all these experts in Madurai. They can do the teleconsultation just like vision centers. So they can just see them, what is happening. And this is what it is. And we are right now with where is Siddharth is here. Siddharth is developing a very interesting biorepository. We have collected 384 whole globes with all the facilities of ARMD, diabetic retinopathy, pre-treatment, post-treatment, and all these things, and have histopathological examination. They can study the basic pathophysiology of the disease. That is research. That is what will correlate with the science. And this is what 354 eyes, number of, and diabetic retinopathy, 13% of them. All these whole globes, it's the richest source treasure in India because we are still doing whole globe enucleation rather than cornea alone. So this is what the richest source which you can think of doing it. And we are, this is the donor eye, from the eye, they are done at AMRF, study the pathology of laser PDR, NPDR, and all those things in the, so it will give a clinical appearance of this. So what you have the richest resource of Pondicherry Hospital, Tirunelveli Hospital, Madurai, all the hospitals with the expert clinicians available to give the diagnosis. And on the other side, you have got the excellent facilities at JVRI with all the facilities available, and yet and they say this is one of the best the research labs which has come up within from 1996 to this is the leading the research lab in country with certified by everyone. And you can see the facilities which are available. Most of you might not have seen it. You must see what are the facilities which we have in our hand, which you can use it, make use of it, not for your fame and the name, but for the contribution to the science. And science, we need not take it for granted, whatever given from other side of the world or somewhere, but you must be able to do with all the facilities what you have, with all the faculties you have. And this is what you have to do. I want you to participate, and all the clinicians, what alumni people are, they are facing the patients. They are the field workers. They can ask questions. They can do that. This is sorry that I have got people only from Madurai clinicians and scientists, but there are clinicians and scientists available everywhere. They are lying there. They are ready to work with you. They are ready to do that. But this is what you have to think. Thank you for having us. But the only thing is what I have to say, this there has been a saying 2000 years ago, நோய் நாடி நோய் முதல் நாடி அது நாடி அதற்கான treatment. So you know the disease, you know the basic cause for the disease, and then treat for it. Not that diabetic of the lacerate, but at least the base for it. So that will help only with the interaction of basic science and the clinical science. Thank you very much.